Welcome to Healthily Conversations, our podcast series talking to health and social care professionals with an obvious focus around communication skills. And today I'm really pleased to be joined by Tony Jermy, Operation Department Practitioner and Academic Lead for Communication and Clinical Skills and Simulation at UEA. Welcome, Tony.
Hi, James. Nice. Thank you for having me. Good to be here.
So Tony, we start these with just going a little bit about your background and I suppose how you ended up getting into healthcare to start with.
Okay, yeah. So in terms of my clinical background, I'm an operating department practitioner. A lot of people don't know what they are. So we are healthcare professionals who specialise working in operating theatres and what we call the perioperative environment. So when you have an operation, you will have be part of sort of three key stages. So you have an anaesthetic stage, a surgery stage, and then a recovery stage where you get over the effects of normally the anaesthetics rather than the surgery. And so we're healthcare professionals that work in all three areas of specialism there. And
so how did you discover ODP as a route?
So I left school not really knowing what I wanted to do, and I nearly became an electrician. Because I knew I wanted to do something hands-on and I knew I didn't want to be stuck behind a desk, which ironically I am now, working in higher education. But my aunt was a theatre nurse and so I was kind of at this kind of crossroads, if you like, thinking, well, I don't really know what I want to do. And she said, well, we'll just go and have a look. They've got an interview day coming up an open day at the hospital at the time. And I went and looked and never really looked back since. I was actually unsuccessful when I went for my first application. I was very young and I guess a little bit naive, but I was given a job in the interim as a support worker, as like a theatre porter, and that was great because it gave me a sort of 6 to 9 months of learning how the NHS worked, and that meant that next time when I went for my interview I was much more prepared.
So many messages in my conversations I have with fellow health professionals that starts with, I didn't really know what I wanted to do and I stumbled into this by chance conversation with someone I knew.
You know, if you'd have spoken to me when I was a kid and said you'd end up working in healthcare and then probably in the university, I would have probably laughed at you. But yeah, like I say, I've found a niche and I absolutely love what I do.
So you were describing earlier the role of the ODP and these three stages of surgical care, and you were describing this background of thinking about being an electrician. So just put a little bit more nuts and bolts, if you were, around what it is you're actually doing as an ODP in those settings.
Okay, so yeah, it's quite a hands-on practical job, and it's a nice balance for me around kind of caring and looking after patients. But those patients are obviously having an invasive procedure done to them, and in many instances they will be under general anaesthetic, so they're really vulnerable. So we have to kind of look after them when they're unable to look after themselves. So there's a lot of technical aspects to it as well. You know, they'll be anaesthetised on a ventilator, for example. A lot of technology that we have with surgery now, so minimally invasive or keyhole surgery is what a lot of people refer to it. So a lot of it's driven by technology, but fundamentally at its core it's around really high quality care of patients.
So we've got technical aspects to the role, we've got a focus, as you say, around care being the central tenet, and we may come back to communication aspects around that a little bit later on. So you started this journey, you did some time working in operating theatres before you got onto the training programme or degree course that you did at the time?
Yeah, so I did about 6 to 9 months as a porter, as a theatre support worker, which is kind of a non-trained role. I then was on a diploma programme, the first ever diploma programme in operating department practice here at UEA, and then I qualified as an ODP, and I worked in clinical practice for probably around 6 to 7 years, and my background, kind of the specialist areas that I worked was general and colorectal surgery and also thoracics.
So the specialisms within ODP are often linked to the clinical surgical types that are operations that are going on. Yeah,
and all of those specialisms will then have anaesthetics as part of it as well. So anaesthetics, I guess, is another area of expertise, of working with anaesthetists quite closely. And again, communication there is really important because we're quite a close-knit team working in high-pressure environments. And like I say, and then you've got your surgical specialities. It does depend on the different hospitals and how they organise their team, but we were assigned to a surgical speciality, if you like, so we could upskill in that area.
And within your training that you went through, I'm imagining there's lots of technical components, but this idea of team managing risk, the high risk environment, and the communication, did that come through at that stage in your career in your training? It
did. There was aspects of it, but we've definitely developed our understanding and education around the importance of non-technical and interpersonal skills as we've gone through the last sort of 10 years or so. It's much more at the forefront of understanding the importance of how that has an impact on high quality patient care.
Okay, so big evolution over the last 10 years, which I think we'll possibly revisit a little bit later on again. So you started this journey, you went into your specialism, and at some stage there's been a deviation from, what may be a traditional career path through an ODP into a world of higher education. And
yeah, absolutely. So one of the things I really loved about my job when I was in clinical practice is when I was able to mentor and look after students. So you would have a student assigned to your operating theatre who went through the same training process that I had, and when I was in practice I would be the person to look after them, the person to assess them, and I loved it. If you had a struggling student, just getting them across the finish line was sometimes a challenge in itself, and if you had a high achieving student, you wanted to push them as far as they possibly could go. I did a little bit of what we call associate tutoring, where you would be in your clinical role and you would come to university and maybe run a few sessions. I really enjoyed that. And then when I got the an opportunity to come over and be a full-time lecturer, I just thought, I've had an influence on one or two students every time, and now I've got the opportunity to have an influence on a whole cohort. People, when I speak to them who I've previously known in clinical practice, they say, do I ever miss clinical practice? And I do, but I get a completely different type of job satisfaction working in education.
It really resonates with me. One of the things I talk about is I can care for one patient and do a fantastic job, but with an education role, I have an opportunity to train a whole range of trainees who are then going to care for hundreds of patients. Absolutely. And the impact that potentially can be given is much greater.
And I always really like the thought of being part of somebody's journey, being hopefully influential in how they then change or go across their healthcare career.
So just picking up the students were coming in for the training. Did you have much training in education, or was that something you naturally fell into?
No, not really. So it's definitely something that I've developed since I've been at the university, and the university is really supportive in terms of education training. I sometimes feel, if I'm honest, like a bit of a fraud when it comes to education, because we take a very different career trajectory compared to someone from a conventional discipline who might have done a PhD first and then gets into education. We're very much employed for our clinical expertise. So it's interesting sometimes, this kind of imposter syndrome that you sometimes get when you're in higher education.
So your current job title as lead for clinical skills and simulation, I suppose is a growing and buzz area at the moment in healthcare education. So tell us a little about your interest and how that sparked into simulation.
Yeah, so you're absolutely right. Clinical skills and simulation is growing in popularity. It's been around for a while in healthcare, but it's often governed by money and finances, because a lot of the technology is quite expensive. But actually, simulation is more about the educational technique rather than the technology, and more and more places are starting to learn that now. And I think it was about 5 years ago that the School of Health Sciences kind of did a deep dive into clinical skills and simulation, and we were doing it. So we were doing it as part of our teaching, but we didn't really have a really coherent strategy around it. So I'm the first academic lead for clinical skills and simulation for the school, and what I've tried to do is develop and grow a faculty of staff who are keen and interested in clinical skills and simulation. And for those of you who have not heard about simulation before, I always equate it, it's like when a pilot goes into a flight simulator. So it's using kind of a technical approach to practice a skill or a discipline in a controlled environment. But it's much more than a technical aspect, and that's where the communication side of things comes in.
So in growing this idea of simulation training, that pilot simulator, if you like, what would be your main learning points to date in trying to set that up and get that moving at UEA?
It's very resource intensive. So I could have a cohort of 250 students in a lecture theatre, and I only need one academic at the front to transfer some learning. It's perhaps not the best way to transfer learning, but it's one way that you can cover a topic. When you do clinical skills and simulation, it's a lot more resource intensive. So you might need multiple rooms simultaneously, you might have multiple staff who need to facilitate, and also it's a completely different way to learn as well. So one of the things we're currently doing is a simulation instructor course for our academic staff who are very skilled in academia, but are learning new skills in terms of how to facilitate simulation, how to perhaps not give everyone the answers straight away like you would do in a lecture, and take a step back and let the learners experience for themselves how they might transition through a scenario, for example. And sometimes that's really challenging, is to take a step back and to facilitate more than to lead or to be a lecturer, I guess.
So if I was either a student coming in to go in a course where I'm being told I'm going to have simulation teaching, or maybe an academic who's not done it before, there's a resource component, but actually I'm interested in what's the output difference? Why should we either invest that resource if I'm at a university, or as a student, what's the benefit of me learning in this way as opposed to a traditional route?
Yeah, that's an interesting... So if you look at the research, the research suggests that we don't really know whether it enhances learning or not. But what I would say is most healthcare students are practical, hands-on learners. And I've never met a healthcare student yet who says, I learn best when I'm sat in a lecture theatre. They love the practical hands-on application of it. In a hospital setting, you're with real patients, and you'll never be able to better that. But equally so, when you're learning a skill for the first time, or even if you're practicing through repetition to get better and better, it really needs to be done in an environment where if you make a mistake, it's not going to mean that a patient potentially gets harmed from it. So the kind of safety in simulation is a really interesting idea and notion, and it's a lot more convoluted and complex rather than just someone potentially getting hurt.
So we've got benefits of trying to replicate real world in the safe haven of a classroom, but actually the reality of what that job's going to look like is very real and realistic for the learner.
I think it's often like we call it bridging the theory practice gap. So what you learn in the classroom and what you experience in a real hospital clinical setting, simulation tries to bring those two together in an environment where we can control to a certain degree, we can guide it, we can manipulate things, and we can then tease out learning. And one of the most important parts of simulation is after the actual activity, where we get together and then we have a debrief and we talk about what happened and the sort of the lessons that learned.
So we're getting into communication and the importance and the influence that may have on learning development and healthcare services. So I'm going to go back to your journey back in the doing the ODP role in a clinical setting, and we started talking about the importance of that surgical team, high risk environment, and the key to communication in that environment. So what would be your key recollections or messages about that environment and communication?
So communication was really important in the operating theatre, and actually I was lucky enough, I guess, to have experienced a global change in trying to improve communication in the operating theatre. So the World Health Organization back in 2007 implemented a global initiative, which is the Safe Surgery Checklist, and this was a series of checklists that are undertaken at key points during an operation. So we do a check before the patient goes off to sleep, because it's really important that we check with the patient certain things like, have we got the right patient, before they can go off to sleep and they can't tell us otherwise, before we make the initial incision. So again, that's a controlled environment. Once you make that initial incision, there is always potential for complication. And then before the patient leaves the operating theatre. And we did a number of key communication checks, like have we given an antibiotic prophylactically because we know it reduces infection rates by about 50%. and other things like have we introduced introduce ourselves by name and role so that everyone in the operating theatre knows who we are. And so I experienced that, what it was like beforehand and how we did checks, but perhaps we didn't go into enough detail, and then what it's like now. And it's really interesting now, listening to my students now who have not known any different, how they would just take it for granted that you would do this, but to have been in a situation where it wasn't done.
And it's really interesting. We've talked on Consultations for Health about Kate Granger and the effort she went to experiencing being a patient, and a number of health professionals coming up to her and no one was introducing their name and role, and how now hello my name is such a standard way that health professionals introduce themselves to patients. But actually it's just as important between teams of staff to know who someone is and what their role is in that
particularly in an operating theatre, because we all look the same. We've all got the same kind of scrubs on, we've got the same hats. In some hospitals you will have a different colour hat if you're a trainee or a junior, as a visual cue to sort of say in an emergency setting perhaps we don't need to demand, but that only depends if those hats are available, so it doesn't always work. So yeah, it's just those little things like introducing yourselves by name and role. You might have a medical student who's there for the first time and they could just be standing on the sidelines and not being introduced, and yet and then something critical happens and either they need to be looked after, or we certainly wouldn't expect that person to get the vital drug or something that we need in an emergency. So yeah, really, really important.
So what seems like a very obvious thing, having checklists at key functional areas and making sure the right people are there, the right things have been done, but actually verbally or going through that process actually has revolutionised, it sounds like, the experience in that environment.
Yeah, and this was actually a concept that was taken from other high-risk industries. So this was taken from aviation. So it was a team of people who worked with Boeing to look at the pre-flight checklist. So it's basically taking that concept. I've got my own opinions on checklists in healthcare. I think we've kind of oversaturated with checklists, but that certainly was a really important implementation. And again, the way it improved morbidity and mortality in the operating theatre was unbelievable. It was better than a drug.
And this may be a challenging question to answer. Several experiences I've had in healthcare have come from when things haven't maybe always gone as best as they could do, and those critical incidents, and reflecting on that. Have you ever had any instance of it that's really made you learn from the experiences you had?
I've had a couple of clinical events that were kind of life-changing to me in terms of, these were once-in-a-lifetime things that you saw. Nothing really that bad, I think, but being able to go over things and discuss as part of a debrief is really important. That's something that we actively try and encourage in simulation. I think it's something that we need to do more of in healthcare, but it's always the case of you have to have time to be able to do it, and when your resources are stretched, that can be challenging. I think, as healthcare professionals, we always need to reflect on what we do, and quite often you do learn from your mistakes. But often that's been an internal monologue for me. I wish I'm never going to do that again.
So you were describing the importance of a debrief, and actually where you may reflect individually and you can do so much yourself, but actually reflecting with other people or talking to other people, you found benefit in that process in the clinical environment.
Yeah, I think I would have found more benefit if we'd have done more of it. And I think in hindsight, now being in education and recognising the importance of debriefing when we do simulation, it's something we should have done a lot more of when I was in clinical practice. There is more of it now. And again, if I use my clinical background, the safe surgery checklist has evolved into having a whole briefing beforehand where the team discuss the whole operating list and then the whole debriefing afterwards. But if there's a pinch point anywhere, it's going to be at that debrief because of lists overrunning, time shortages and stuff like that, which is a real shame because that's probably where the most beneficial learning is going to come from.
So as we transgress back to the education and back to the simulation environment, you were describing the importance of actually we do a simulation, the students have a training experience, and then we have this debrief part at the end. Now, for several listeners, a debrief might sound quite a formal word. So what does that involve then?
So a debrief is an opportunity to review what happened during the the simulation event. So again, what you're trying to do with simulation is to create a scenario or a set of circumstances to develop the student's learning using normally some kind of practical skill or a scenario, but it's not just kind of the practical, technical proficiencies, it's developing those non-technical skills as well, those interpersonal skills. And so what the idea of the debriefing is to use kind of a reflective conversation to then identify what happened in that event and then to tease out learning. So when you're doing clinical simulation, it always really needs to start with some defined learning outcomes. So if you're an academic who is trying to develop a simulation, okay, what are your learning outcomes? What are you hoping to achieve out of this? So it might be around developing teamwork or cohesion or the importance of decision making in time critical events, for example. So you need to go back to those learning outcomes, and my role as a debriefer is to guide the conversation rather than lead it again. But people can quite easily go off on tangents, so you just have to sort of steer them back into the conversation. Quite often also you need to explore unintended learning outcomes, and I can write a simulation and deliver it to 3 or 4 different groups, and every single event will be different because of how the individuals react and behave in those situations. And so what you have to do as a skilled debrief facilitator is achieve your outcomes, but also sort of tap into the unintended learning outcomes. And in some instances, you might sort of shelve your learning outcomes completely because an event happened that was so critical that you have to kind of unpack it and address it. And it's to get the learners to reflect, to support each other, to create an environment which is supportive to learning, particularly if something goes wrong, because that can be really, really challenging. You know, if a student should have done A, but they did B, that particularly if it means in the clinical context, it would be the difference between doing something right and wrong and a patient potentially getting harmed or injured. You have to unpack that. You can't just go, well, you did really well and kind of brush it under the carpet. And so it has to be a really supportive learning environment. And again, you kind of foster that with the people that you're debriefing. And that actually starts before the simulation event. We kind of do pre-briefing, and we do something called psychological safety, where we kind of tell learners that this is an opportunity to learn rather than an opportunity to be kind of assessed and critiqued and have everything examined under a microscope.
I was just going to say, I suppose if simulation is probably something lots of students wouldn't have formally experienced in their early education before they come to that healthcare environment. So I was interested in how you would explain or unpack that. What's that going to experience or be like for them? So you've described there's a pre-process. So explaining what's going to happen and what you're trying to achieve. Yeah,
so if we kind of remove all of the planning that goes on from an academic point of view, if it's actually the event that the student's involved in, you have a briefing first. Again, I would clearly state what my intended learning outcomes are, so it prepares the learners for the event, then establish some kind of psychological safety. What I try to do is flatten the hierarchy, so the learners will always look to you as the academic, and there'll always be this kind of unspoken level of anticipation or concern, if you like. So I try and level the hierarchy. So let's say I'm doing a simulation around a clinical event that happened in an operating theatre. I might talk about my experiences and my vulnerability when I was in clinical practice, so that they can go, oh, actually, it's not just us and them.
Yeah, we're not putting the teacher on a pedestal. And they're always going to get it right.
And again, what we're trying to do is prepare them so that when they do the simulation event, that they conform to the best of their ability, even if it's challenging. And it's okay to be challenging. But what we don't want it to be is a threat rather than a challenge. And so they do the simulation event, and most of the learners, that's what they're focused on. They probably don't realise what we're doing in the briefing to help them. They're focused on the event, and then they probably not even thinking about the debriefing. And the debrief is where most of the learning comes from. So the focus is often on the actual simulation activity, particularly if you've got fancy kit and equipment involved as well. It's all very kind of snazzy and exciting. But it is the debriefing where all the learning really gets teased out.
And And it's interesting you're trying to separate the idea of assessment. So often we would talk about students are driven by the assessment. What's the test? What's the thing I need to pass?
Yeah.
And you're trying to separate that from a simulation experience.
Simulation can be used for assessment, and that's what we would call an OSCE, which is a practical exam. But and perhaps that's what students are expecting when they do simulation. But full-blown simulation, which can, and again, what you're trying to do with simulation where possible, everyone knows it's not real, but you're trying to momentarily get them into what we call a fiction contract. So they just suspend disbelief momentarily. They're in a classroom somewhere which perhaps looks and feels like a real environment, but everyone knows it's not real. But if you get it right and you get the design of the simulation and the emotional buy-in from the learners, they can just for a moment forget that it's not real and then get really sort of sucked into it. And it can be really emotionally charging and thought-provoking. And again, sometimes you have to unpack that as part of the debrief as well, even if it's a case of just going, I think we need 5 minutes where we can all just relax a little bit before we then discuss this further.
So formally in a course that may include simulation, I'm going to have these range of experiences. I'm going to have this debrief that I'm picking, and as you described, that's where the real learning happens. In courses, would there be an expectation that then they've got to package that back up together to show that they have got that learning and development in any way, shape?
No, not necessarily. And I think skills and simulation can be used across if you've got a 3-year Bachelor of Science degree, you can do a skill in isolation in year 1 where you might be learning the skill for the first time, and actually it doesn't have to be really detailed and lots of depth and character development and that kind of thing, because you're just learning the skill, and then you can build layers on it. So then you might then incorporate that skill into a learner using that alongside lots of other skills in a patient scenario. And then you might do something like a full-blown event where you've got multiple patients simultaneously in year 3. So as with lots of other kind of learning techniques, you kind of build the layers of complexity on. And you might want to attach an assessment to that as part of it, a practical assessment like an OSCE, but I think it's completely optional. It's just a different way of education and learning.
And on one hand, simulation is new, but it's not new. It's been around for years in slightly different guises. I suppose where do you see the future of this type of education going? What would you like to see happen over the next 5 or 10 years? So
what I'd like to see is much more refinement of it as a technique, much more development of the facilitators that we have, because what happens in a lot of places, and not just in higher education but also in hospital settings as well, if they have a simulation centre, is often the enthusiasts that really run with it. So I'd like to see more recognition of it as a real kind of defined way of learning in healthcare curricula. I'd like to see more simulation after people finish their training. So for the actual healthcare professionals when they're out there, they need to do as much simulation as what we do before they finish their training. And again, if you look at other industries, you look at aviation, pilots will go in the flight simulator every 6 months to achieve a set of competencies before they can go back out onto the planes again. And we perhaps don't do enough of that in healthcare. And we can practice the extraordinary. We can practice what happens when someone has a once-in-a-lifetime reaction. But we can also use simulation to look at the mundane and to improve it, and not just use it as a way of developing education, but use it to improve patient safety. So there's a technique called in situ simulation where you actually do it in the hospital setting and environment, and that's great for looking at things like procedural irregularities. Have they thought about the design and layout of the ward? Is the cupboard in the wrong place, which means that drug errors are occurring, those kind of things. And you can tease those things out with simulation as well. So I'd like to see it being used a lot more to improve patient safety as well. So there's get a baseline of it established as a recognised educational approach, and actually build the benefits of that into a longer term career where people are re-engaging that competencies, rethinking, reflecting on the day-to-day stuff they do in the real clinic, and having a chance to go, actually, we could do this differently, or there's a different way of doing it. It's a great way that we could make really meaningful change.
And you mentioned one of the things, the knock-on things that come out of this is not maybe the fundamental, this is their technique or approach, it's the softer skills around that, and again, coming back to the communication with the team that's coming out of this.
Yeah, I mean, again, what we often do when we're introducing a skill to our learners is we practice a skill in isolation. So if I take a real simple skill like taking a pulse, the first time that a learner learns how to take a pulse, you need to feel in the correct place so that you can actually feel the pulse, that you can get some feedback, you can count the amount of heartbeats in a minute, you can feel whether it's a regular rhythm, you can feel whether the pulse is weak or whether it's bounding. But when you do that in a hospital setting on a real patient, you never do it in isolation. It's always linked with other skills. It might be linked with other technical skills. So pulse check might be part of a larger set of checks, also taking a blood pressure or counting respiratory rate. But quite often it's involved with interpersonal skills. So, you might have a patient who is anxious or nervous or has lots of questions that they're trying to ask you while you're trying to check a pulse. So if you practice that skill in isolation, great, you might be able to check a pulse. But in reality, it has, again, layers of complexity. And so what simulation can do is add those layers of complexity. And you might want to do lots, different approaches. So you might want to practice the skill in isolation first, and then you might want to then run the simulation again and go, yeah, so this time you're going to do it on a patient, but your patient is going to be anxious, nervous. You have to either stop them from speaking so you can concentrate or answer their questions, and then you have to provide feedback on what you found out and develop those communication skills as well.
And one of the things you mentioned early on is the resource-intensive nature of simulation teaching. And if we were going to do all those things with each of those 200 students we traditionally had in a lecture theatre, that is an awful lot of time. So is there benefits for those who may not get to do the hands-on bit in using simulation as part of their education as well?
Absolutely, yeah. And so large cohorts present a real challenge. You can either make your larger cohort smaller by having multiple skills groups and then running the same thing over and over again. That's a technique that we use, and it often means that a cohort of about 150 to 200, you might have to run the session 10 different times. And those groups are still large for doing skills and simulation. So if I'm doing a full-blown patient simulation with a patient scenario, I probably want a maximum of about 6 to 8 people for learning. But you have active participants, but you often have learner participants as well. So if you've got the facilities and the resources and the technology that people can watch things remotely with camera and AV, that's fantastic. And they'll often be able to see things that happen in the simulation that the people actively involved won't be able to. So there's a phenomenon called situational awareness. When you're actively involved, and particularly if you're task focused, you lose your global perspective of what's happening on you. You're like a horse with blinkers on. And so people watching remotely will be able to see things. They'll notice that something took longer than what the person involved in the simulation thought it did, for example. And again, if we can unpack that in a debrief, it provides a much richer learning environment. So yeah, the misnomer that you have to be actively involved to learn is something that I'm trying to work against where possible.
So we've gone through a whole journey in our conversation today, Tony. We've talked about that initial journey for you as being a trainee ODP or getting in that environment, the importance of working with the surgical team, and the revolution of the need for communication checklist, and that simple thing of introducing who I am and what my role is being really key to success. And then that journey into the educational side and simulation-based teaching, and how actually by giving people that opportunity to work in a safe but yet realistic environment. But the key thing I'm hearing throughout this is we need to talk and we need to debrief more and get learning and share our experiences and work out what worked and what didn't work effectively as part of that process. If you were to give one sort of tip to maybe your students or future healthcare students, have you got a tip or an idea you would give to them?
So tips in terms of communication, I would say try not to make assumptions. And if you are going to make assumptions, if you can, try and declare those assumptions. I call assumptions communication baggage. And, we do it as human beings all the time. We don't have 100% of the information 100% of the time. And so we have to fill in the gaps. And we often do that with assumptions. But when it's in healthcare, that assumption could be the difference between getting something right or wrong. Also, little things like closed loop communication. When you're talking to someone, and it can sound patronising sometimes, but if you get them to repeat it back, the message has got across. So we practice using handover communication tools like SBAR, which is a technique to hand over in a structured way, I always say at the end of that, get the person to say it back to you. And you can package it in a way that it doesn't come across as condescending. So I often use a technique where I go, can you just say the main points back so that I haven't missed anything? And that kind of puts the onus on you.
Back on you, yeah.
You'd be amazed how many people nod and make all the right noises and gestures, but actually they're not listening to everything that you're saying. So communication is only effective when both people have got the same out of it. So little tips like that make a big, big difference.
So we've got some fundamental ideas around assumptions, and if we've got some, make them clear, make them explicit with who we're working with. And communication is a two-way process.
Yeah.
And actually, until we've had that confirmation from both parties engaged in that, then we can know communication's been successful.
And debriefing is really important as well. And you can get so much out of it. And even when everything goes well, you can still debrief. You know, what would we do even better next time? We're guilty sometimes in healthcare of just focusing on the negatives, waiting until something goes wrong and trying to fix it. Actually, we should do more of, that was really well, that went really well. How can we make it even better?
This has been fantastic. Thank you so much for your time today, Tony. I'm sure we will have to have another catch up and see how simulation-based education has evolved in the next few years. So thank you very much for your time today.
Thanks, James. Thank you. Really